Welcome to CareLab.
Welcome to CareLab. We're so excited. We've got Helen Bauer back here with us on CareLab today. Helen from Heart of Hospice, which if you haven't listened to the Heart of Hospice podcast, you should definitely listen to it just as soon as you are finished listening to this episode of CareLab, of course. Helen's back here with us again today to talk about some more really important issues in hospice. But first, we've got to have a fun little icebreaker question. So, and I've got it today. Are you two ready?
Uh-oh.
I'm ready to go second. Yes.
Oh man, was that the bus driving over me? Okay.
Exactly.
Yes.
Just giving you a small bit of warning.
Thank you. Thank you. Okay, I'm ready.
This one it's not too bad. Listen. So, actually this is a total softball. Where in the world do you absolutely have to go, like before you die? Where's one place that's on your bucket list? You've got to make it there that you've never been before.
The Camino de Santiago. I can't even say it right.
That's a good one.
Yeah, the Camino. It's like a spiritual pilgrimage. It's been around for centuries, and you can walk it through Portugal and Spain and all these different areas from different directions. It's a hugely historic, well-traveled path, and I really, really want to do that.
Yeah, my stepmom actually did that earlier this year. She did.
Really?
Yeah, she did, I think, 300 miles of it earlier this year. And and everyone that I know, I know two people who have done it, but like life-changing experiences for them.
Yes. Yeah, I would love to be able to do that. It's traditionally it ends in Spain. There's a basilica in a city there, but pilgrims have been traveling. The Portuguese route through Portugal to Spain is a big one, but there are several different approaches you can take. I would just love to do that, and I want to do it while I'm in good health and good shape because it's pretty grueling. Mm-hmm. Not like mountainous or anything. It's just the distance. It's an endurance thing.
Yeah, that is very cool. That's a great one. Brandy?
I don't have anything as awesome as that, I don't think. Mine is, I have a whole bunch of places on my list that I need to go. And, I don't like to choose favorites. However, the place that was on my list the earliest in my life that I have yet to go to is Australia. And so I've never been, and I really want to go to Sydney and more places than that in Australia. And yeah, that's my place.
Yeah, Australia is really high on my list too. And my husband's been there, but I've never been there. And I just feel like anytime you can get to another continent is pretty cool, right? Mm-hmm. Yes. I would have to say though, I absolutely am like drawn to this idea of going to Egypt someday. Mm-hmm. I just like really want to see that part of the world. Of course, I want to see the pyramids. And there's just something that I want to go to lots of places in Africa, actually. But like Egypt just draws my imagination. And I really, really want to go there someday.
Very cool.
Mm-hmm. That's a good one.
All right, guys. Should we
bucket list before we die? Hospice.
Yes.
That's our transition.
Oh, very good.
Thoughtful.
So we've had a conversation before. And Helen, we really appreciate being on the podcast before and having us on your podcast. Oh. And I think the thing that Amelia and I were thinking about when we, as a topic that we thought was really important, also because it happened in my own life, was how can we have the conversation with others about considering hospice? And this comes from like a couple of different ways. I am at the same time a healthcare professional who might talk about it this way. And I'm also a daughter and a niece and, a family member to people who might need to be on hospice. And so like those two roles are very different. And even though I hold both of them, most people don't hold both of them, but they still have this like tinge of how do I bring this up? Because I love this person or because I really care about them getting the services that they need, right? In our last episode, we talked all about how beneficial it can be. And so like just, we need to know the words. Give us the words.
Oh gosh. I wish I had the right words that are cookie cutter that would fit every situation.
That doesn't exist?
Oh, I wish. But for healthcare providers that actually are family members that need to have those conversations, I think actually that puts us in sort of a good position. But the best piece of advice I could offer to anybody, whether you're a healthcare worker or a family member that needs to talk to your person, is have those conversations early. Bring it up way in advance, because it's super emotionally charged when you're in the middle of a crisis.
Mm-hmm.
So really, discussion of hospice should be part of your advanced care plan conversation, right? That should be in there somewhere. But an ambulance is a really bad place to have an advanced care plan conversation.
Do you think that having that conversation early on, and maybe even like really it's a conversation we should have with people, just talking about what our end of life care preferences are when we're not sick, when we're not ill, when we're not expecting it, right? But do you think that talking about that earlier on can help to decrease sometimes the fear that people have of when that specific word like hospice comes up? Because I know a lot of people are they just don't even want to hear the word. It's too scary because it indicates that, you know, the end of life is approaching, maybe sooner rather than later. So you think talking about it earlier kind of helps to destigmatize it a little bit?
I do, because when you have those conversations upstream, you know, way distanced from a crisis or a serious diagnosis or, you know, bad healthcare news, you're taking out some of the additional emotion and grief and maybe depression and worry and anxiety and fatigue and all of these things that people are dealing with when a serious illness has gotten significant. And you have a little space and a little mental bandwidth to be able to have a conversation. And, you know, anxiety heightens your fear responses. So if you have less anxiety, things are rocking along and you're just talking about what you might want at some point in your life or your illness, then isn't it so much easier to have a conversation? It just removes a lot of the weight of that word hospice. It also gives people some time to explore what hospice really is. When, you know, most people have a lot of misconceptions about what we do in hospice. You know, people are hanging halfway in, you know, one foot on the banana peel, one in the grave when they go on to hospice, which is not true. You don't have to be actively dying to be enrolled in hospice. But a lot of people see it that way. So it really is, it's immediate death. When in reality, okay, so think of former President Jimmy Carter, right? He's become sort of the poster child for being on hospice for a year. It doesn't have to be that way. So if we have those conversations earlier on, I think we just process that information better. And it also gives us some time to explore it a little bit deeper. We don't have to say, okay, I don't have much time at all. My mother just had a significant stroke and I need the nuts and bolts, you know, the Cliff Notes versions right now so I can act. Well, you have the luxury of time to be able to have conversations that are more relaxed, not as heated, not as emotional. I think there are a lot of benefits to moving those conversations upstream.
That is so simple when you say it, but like so powerful. For like my parents and I have had advanced directive conversations. They wrote all their stuff out and we talked about it, and we did not talk about hospice. You know, we talked about everything around it. You know, we talked about what do you want to happen at the end of your life and what kind of care do you want, and like, but we've never talked about like, oh, if this is the kind of thing that you want, then this also bodes well with choosing hospice at this point. And that just wasn't like plugged in there. And saying it in advance, or I should say like when you're planning, it makes so much sense, because then when you bring it up, it's like, hey, remember we talked about if these kinds of things are happening, you would want this kind of care, and we can get that through hospice. How do you feel about me getting somebody to come over to talk about that? Then it's not like jump out all of a sudden, never thought about it before in my life, and now I'm talking about it now, so which means my life is over. It's like, okay, this is the next step that we're gonna take at this point, you know? It feels like all of these like prefab advanced directive letters that we put in hospital folders and we try to get everybody to do should say, do you want to have hospice? And even though it's just like, you can just check a box, but at least it went across your eyeballs and you had to like think about it for a second. It's not your first time.
Right. It comes to your awareness. I think that's really an important thing, just to start bringing up the concept of hospice. But healthcare providers are just as bad. We don't make time for those conversations. We say we don't have time for those conversations. We don't want to document them. I think a lot of times healthcare people don't want to have those conversations, because when you start talking about end of life, all that psychosocial, emotional, family discord, disagreements, bad relationships, all that stuff comes up, and then we have to deal with it, which takes a lot of skill, a lot of finesse, and more time. And I think sometimes we just don't want to have those conversations because it's a pain to do it. It's more work. It's more work than we have time to do.
Hey there, it's Amelia. Listen, I am so thrilled to have a great resource like Ask Sammy as part of the CareLab team, and here's why. It's a game changer for aging in place because it makes it so simple. All you do is ask. Just type in your question or even tell Sammy what the problem is and get tailored solutions. Everything from innovative adaptive equipment to comprehensive resources. It's a great way to become more empowered, to live more independently, and to live with greater confidence. And my favorite thing about how Ask Sammy works is it's deeply rooted in dignity and practicality. So whether you're a fellow therapist, a care partner, or someone who's seeking solutions for themselves, visit www.asksammy.com. We're going to link it in the show notes so you can find it there. Start making home more accessible today. Now, back to the show. Yeah, I definitely feel like I've seen that in my own practice as an occupational therapist, getting an order to see someone or walking into a room for a patient, and it's interesting. And the role of a therapist is not to tell someone when their end of life is near. Like, we don't diagnose, that's outside of the scope of the services that we provide, or, certainly ethically should provide. So it's not my place to say, let's start getting ready for end of life. Like, this is what's going to happen. But of course, as their provider, I usually know what the likely outcome of a situation is going to be. And it can make it really hard to provide the correct services that a family needs at that time if they haven't already had a conversation with the physician about what reasonable expectations of an outcome might be. Because there's sometimes when I can really have a great impact on doing things like comfort training for positioning, caregiver training, like there's a lot of things that we can have a positive impact then. But then if the family is not on that page, right? If they're still thinking, well, let's get up and go walk 300 feet down the hall, it's an awkward position to be in, and definitely makes it harder to provide the services that someone really needs too. So yeah, I think your point is well taken, that like sometimes as providers, I'm not trying to put this all off on doctors, by the way. I think every provider at every level, like there are times when maybe someone is on hospice and the therapist should be going in there and talking about, comfort procedures. And instead, maybe they're thinking about, well, let's get someone more independent. So this is not at all to say like this is all on physicians or there's one party that's guilty here. But I'm just saying, like, when everyone can be on the same page, it really does help to create a better outcome of quality of life, which to me is what hospice is really about. It's not about death. It is about the quality of life of the person wherever they are on that particular journey.
It's true. It's all about quality versus quantity. But I do think it puts our therapists, STOTPT, I think it puts them at a disadvantage when the family has completely different expectations about what the treatment should be and what the goals are, because the rest of the healthcare team never had those conversations with the family or the patient before the therapy referral was made. So sometimes, I think sometimes different disciplines get kind of stuck in those conversations. And I agree with you. It's not all on the doctor. I think that is the foundational point where those conversations need to be initiated. But there's so many conversations that need to happen because advanced care planning is never one and done. You never want to mention hospice and then just leave it there. That's not enough for anybody. It's too much for any one discipline to do. A doctor can't do all of that. A nurse can't do all of that. And I think each of us brings a skill set from the perspective of our discipline and what we do, where we can talk about hospice and add value to the conversation.
Yeah, I agree with that a lot because while it's not my place to like diagnose what you're going to do or how long your life is going to be, if you have a progressive disease that we know what the end outcome ends up being, that's not me. You've already been diagnosed with that. And so I'm just helping us figure out how we're going to deal with it from here to there. And so one of the ways I've backed into the conversation has been through equipment and thinking about like, okay, we have this progressive disease diagnosis. You need these things at home in order to be as safe and as independent as possible for as long as possible and to make caregiving as easy as possible. That's my job as an occupational therapist. And so, yes, we should figure out how to make that work for you now, but we also should think about how do we make that happen in the future because we know this is going to change, right? This is how the words I'm kind of using. And it's really beneficial that hospice covers like basically everything that you need in order to be as comfortable as possible at home. And so I've brought it up in that context, and I find it slightly easier to talk about it as a healthcare professional than as a family member, and just be like, practically, instead of you trying to buy a hospital bed or get an adjustable bed, or get all this additional care, we might want to just at least talk to hospice and see if it's the right timing for that, because they might be able to provide they can provide those things for you too as part of the plan. And so we've gotten to that point from that incremental like thinking through, okay, we know this, we're trying to do this, but we also know in the future that maybe we should also have this conversation too.
I really like that. That's a really neutral approach that doesn't seem overwhelming or, hitting somebody in the face with it. I love that idea. As your needs change, if and when your needs changed, we have already started looking at this, helping you prepare for it. And then, there's a plan in place. And I think most people like to have a plan. As much as we are death phobic and want to deny what's going to happen, I do think people like to have a plan and they like to be a little bit proactive. And they definitely look to their healthcare providers, the different disciplines, to be the ones who are helping them look down the road. I mean, we're the ones who are supposed to be the experts in our areas.
So, what's some advice that you might give to family members or people who are caring for someone who has a terminal illness? And it could be, far in the future, it could be, impending more quickly. But what kind of advice would you give them in terms of initiating helpful discussions with providers when maybe the provider seems hesitant to have that discussion? Does that kind of make sense? Because
Yes.
sometimes we have to, sometimes you're right, like we can't, sometimes our providers don't want to have these conversations. So how can we kind of have conversations to sort of like nudge that along and open up the door so that we can get to that space of openness in order to get the person we love what they really need?
What strikes me about that question is it's sad that we should even have to,
It's so sad.
right? That we should even ask that question, that it's
Yeah.
there. But it's true. And there are a lot of different reasons that your healthcare provider wouldn't initiate or wouldn't bring up the topics. But I believe in person-driven care. You know, my mom's generation, for them, what the doctor said was gospel. If he said it, you did it. And maybe you didn't want to do that, but the doctor said, so that's what you do. I think baby boomers are different. I'm not a boomer. I'm just a year off of it, though. I think we're different. We want to drive our own care. We want to be independent and self-actualized. We're information-based. We're looking for the science and the evidence. And we want to bring up those conversations. So my suggestion is when you're sitting with your main healthcare provider, tell them, I want to talk about my advanced care planning. Just be direct. I want to make time to do that. If we can't do it at this visit, because I'm bringing it up, I want to schedule a visit with you to do this. I also think that people need to do some research and some preparation on their own. Because let's face it, if you're counting on a physician to sit down and have an hour-long conversation with you, that's probably not going to happen. That our healthcare system is not set up to care for human beings in that way, to be able to invest time. It's a shame and it's broken, but I think what we need to do is to learn how to be advocates for ourselves inside this broken system. Because if you wait for the physician to have an hour-long appointment, you know, for the system to be fixed and scheduling to be different, that's not going to happen before we die. I mean, change like that is huge and it just takes a really long time. So be a direct advocate, communicate very clearly. And if you have a provider that does not want to have that conversation, hear me very clearly, you probably need another provider. Any physician worth their value is going to be willing to have those conversations. Even an oncologist. So we hear this a lot, you know, oncologists and people who work with cancer patients, they don't want to initiate those conversations because they don't want to steal the hope of people who are receiving treatment for advanced stage cancers. And I get it. There's a lot of psychological benefit to hope and positive mindset. However, what we have found is that the science bears out people want to know the truth. They feel more comfortable with the truth. And to me, when you're talking about making people feel more comfortable, that's quality of life. And if accurate information and deep conversations about how they feel about their own hospice care and end of life contribute to that comfort, then that's our goal all along. Do no harm.
CareLab listener, I have a question for you. If someone you love needed a caregiver, what qualities would you want that caregiver to have? You probably want them to be reliable, trustworthy, kind, maybe just a generally dependable and good person, right? Second question, would you also want them to be trained? I'm gonna guess the answer is a definite yes. Okay, third and final question for you. Do you think it matters who gives that training? Like, is it cool if it's just in your body, or would you want that person to be a qualified expert? Assuming you do, in fact, love this person who needs a caregiver, you probably want the expert, right? Well, that's what Higher Standards Caregiver Training does. Higher Standards Caregiver Training provides 100% occupational therapist-led training for caregivers. Caregivers get taught everything from gold standard foundational skills for transfers and daily living tasks, all the way up to how to deal with specific diseases and injuries. And most importantly, they are taught all of these things in a way that is practical and enhances the participation of the person who needs the care. And it actually protects the safety of everybody involved. Why? Because everyone deserves a higher standard. For a course for individuals or learning about training for care for organizations, find that information at higherstandardscaregivertraining.com.
Yeah, I think that's a really good point too. I also think that if, like, kind of to add on to that, if people really know and understand what their prognosis truly is, they might make different decisions about the care that they're receiving to prioritize other things in their life. And that's, we all deserve to have that choice. Like, that's a right that we all have, is to make our own healthcare decisions. And the only way you can make a clear-headed healthcare decision that is right for you is if you 100% understand what the possible outcomes are going to be, right? That's just what it comes down to.
So I would add to that. So we don't want to sound like we're truth shaming,
Of
because
course, yeah.
because it's not for everybody. I have a friend whose wife had advanced cancer, and she chose not to receive any of the information. She wanted him to make the decisions. She didn't want to know test results. She wanted to be told by the physician what the treatment options she wanted her husband to be told what the treatment options were and let him choose, because she didn't want to carry that with her. And so here's the kicker. She was a palliative care physician. She was a doctor.
Wow.
And an American. And, in the United States, we're really big on patients' right to their own information and making their own decisions. But she literally fired a physician who tried to tell her all these test results during an appointment. And she said, I gave you specific instructions that I was not to be informed about this piece. Wow. And she stopped seeing the doctor and got somebody else who would comply. So there are people that choose, and there are a lot of different reasons people choose not to have those conversations. It's, it's cultural. There are religious and faith beliefs that people subscribe to that make those choices different. So I do always want to say, when we talk about patients' rights to choose how the information is given, I never want to shame anybody for not wanting. If you have a reason that makes you comfortable and you can move through your treatment, through your end of life care without having all of that information, more power to you. That's entirely up to the person.
I think that feeds right into the same thing. It's like, it's still a choice, right? Yeah. And so the choice might be to not have any information. The choice might be to get all the information. The choice might be, I don't want treatment for that. And I want to spend my time doing other things and not be in the hospital or at rehab this whole time, And so, like, I think the most important thing is, like, if you don't have at least some information, then you can't make a choice. So what I mean by that is, like, she didn't decide that just willy-nilly out of the blue. She got a diagnosis and then decided, okay, I don't want to have the test and information because I want to be whatever she wanted to do. But it still had to be a conversation. She had to talk to her husband about it. She had to think about it. And, like, I think that's like it feels like what you're telling us is there are no cookie cutter answers to how to bring up this conversation, but that the best way is really to do it sooner rather than later, and not in the heat of the moment, which is great advice in general, right? So I don't know why we didn't think about it applying to hospice, but, like, it's something to think about at the beginning, and not when you might have to need it. So I have this other question though. So that brings it up is, how about palliative care? So we're talking about, like, the word hospice, and there's this other thing called palliative care, and I think it's a slight bit confusing, and I know it has a lot of things tied to it, but I really like it if you could untangle that for us. And, like, is it better for us to say, hey, let's talk to palliative care, even though I'm thinking that we should talk to hospice, but I'm not saying the hospice word, and maybe it goes over better? Or should we just, like, be grown-ups and, like, say the word we're supposed to say? Like, tell us how you feel about that.
I like the way you say that. Be grown-ups and just say the word we need to say. I'm a very direct communicator, and I want the grown-up words. That's easier for me to process information and make decisions from. It's not always appropriate for everybody. So when it comes to hospice and palliative care, they are two different specialties. And there's so much confusion, not just out in the public, but in healthcare healthcare providers themselves don't always get what hospice and palliative care are and how they're different. So the simplest way I can define that difference is all of hospice care contains palliative care, but not all palliative care is hospice. So palliative care can be provided in conjunction with aggressive treatment, chemotherapy, radiation, etc., all of those things. With hospice, it's about comfort measures and symptom management, not so much about the aggressive, looking for curative treatments. So but it is super confusing. And I think people approach a physician and say, I'd like to have a palliative care consult. I would like to talk to palliative care. And the answer they get is, well, we really don't think we're at that point. And you have to have the gumption to say, I'm not talking about end-of-life care with hospice. I'm talking about palliative care. But yeah, there's a lot of confusion. Palliative care is the new kid on the block when it comes to medical specialties in the United States. And I think a lot of healthcare providers don't even know exactly how to tease that one specialty out and figure out what it does.
So if it's not about end of life care or getting close to end of life care, then why would somebody say, I need a palliative care consult? What is it that you're getting just from palliative care, knowing that you're getting palliative care with hospice? But what do you?
Right. So palliative care on its own as a specialty provides an additional layer of care, which also includes a team that's very similar to a hospice team, an interdisciplinary team, social worker and chaplain, the nurse, things like that. They look at symptom management, but all of it is quality of life and comfort while you're still receiving your treatment. They are also really great at having advanced care plan conversations. And in a lot of ways, palliative care is a transitional specialty. And to all the palliative care folks out there, forgive me if that seems insulting, but it is a transition and a stepping specialty towards getting towards hospice and end of life care. It's sort of a precursor, like home health is a step in between aggressive care and hospice.
But palliative care is also something that can be received if you don't have a terminal, diagnosis too, right? Like if
Right.
let's say I got in a bad car accident and I was going to survive, but I had a lot of broken bones. It was really painful. I was going to be in the hospital and rehab for a while. I could still receive palliative care, even though I was no longer at risk of like expiring from the injuries from that accident, right?
Right, because it's about comfort. So people with chronic illness can have palliative care as well. Yeah, you don't have to have an end stage diagnosis, So even those advanced care plan conversations, maybe that's not one of the parts of the plan of care from a palliative care doctor that you would need at that moment. But they're still providing support for quality of life, symptom management. They're looking at your psychosocial needs. And it's well-rounded interdisciplinary care. But no, you can have it when you have a traumatic injury or an accident, a chronic illness that needs management. There are a lot of different scenarios. I think it's very underutilized as a specialty.
But I kind of like it almost brings it back what you were saying before. This kind of brings it back full circle to where palliative care can be a way that this idea of hospice gets introduced earlier in a conversation for someone. So that kind of like brings the conversation almost to a full circle. They're saying like, well, we started by saying we should have these conversations early. This is one way that maybe those conversations can be had actually earlier, with everyone kind of being involved and getting on the same page, so it's not so scary when that time does actually come.
Absolutely. And that is one of the interventions that a palliative care team provides. When the conversation about hospice needs to happen, they're very knowledgeable about hospice care.
Well, I think that we CareLabbed the heck out of this one. I think
I
did some
agree.
excellent care labbing here.
You guys always do.
Helen,
Helen,
we're really
thank you.
thankful for you, yes, coming on the show and helping us untangle that and like giving us, you didn't give us the words, but you gave us a lot of words,
Hmm.
so that we could have a way to think about this and like have a conversation when it's not so heated. So thank you.
You're welcome.
Yeah,
This is
thank
the one last thing I would say is that when you need to introduce the topic of hospice, if you do it with compassion and empathy and respect, you're not going to use the wrong words.
Mm.
Mm.
That is amazing advice and words of wisdom to wrap up this episode with. Helen, thank you again so much for being on another episode of CareLab. As I said at the beginning of the episode, y'all, after you make sure to leave a review, like, and subscribe to CareLab, make sure that you go check out Helen on Heart of Hospice. It's really, really a amazing podcast. And if you enjoyed this one, I know that you will get a lot of value out of listening to Heart of Hospice as well. So thanks again, Helen, for being here. And we'll see you all next time right here on CareLab.
Bye, everyone.
Bye.